It's a real pleasure and honor to be back with you guys. I've come to realize as my parents are in their 80s how important it is to have a nurturing environment for a kapuna. And so being here with you who have built and tended to Hawaii these decades, it's an honor to share with you some of the work we're doing. My topic is going to be on spine augmentation and vertebral compression fractures. In short, as we age, our spines weaken. They have microcompressions, they fracture, they bend, they collapse. And here are some of the things that we can do interventionally to get them better. But before I get to the meat of this, I wanted to give you some sneak peeks about what's coming up in the Neuroscience Institute. The big one, and hopefully Kamal will invite us back to give a talk on this in the future, is focused ultrasound. All of you must know someone who has trembling, whose hands shake, hard to write, hard to drink. We will now have the option to treat some of these patients here using focused ultrasound. What is this? In your brain, your basal ganglia help modulate movement. And we can now use ultrasound energy to heat that area of brain, and you go from to minimal. And that'll be there. I'm not talking about it today. Don't ask questions, but we'll be back and you can hear about it. But Kamal has my information. You can email me, Dr. Michiko Bruno, who many of you probably know, Dr. Fei Gao. We will be working with Dr. Morita as well, Michon Morita, and we'll be offering this in a couple months. Next, we are in the process of building a CSF Venous, Cerebral Venous and CSF Disorder Center. It's my key research. I currently serve as the chair of my society's section on this set of disorders. We're learning a lot. We just submitted for a new ICD-10 code so that the powers that be acknowledge that this is a group of diseases. How does this pertain to you all? We manage some types of continuous headaches, CSF leaks, which can result in chronic fatigue. You may or may not have heard of normal pressure hydrocephalus or pseudotumor cerebri. These are two different things in medicine, but we manage those. And then there are some patients that experience cognitive decline from these diseases, so we will be putting this online as well. So this is a teaser. Now for the meat. So why do we go from this straight, upright young lady, and then 25 years later, her spine is curved, collapsed? We've all seen this in our lives. The answer is because our spines collapse. And the way that spines collapse is because the bones soften, the minerals go away, and they start to collapse. We're going to talk about two of the implications of this and two of the treatments. One is kyphoplasty, and the reason why we call it kyphoplasty is kypho means kind of angulation and bent forward, kyphosis. Plasty is to change the shape. And then the other is sacroplasty. When we see people with sacral fractures, you probably all know someone who's had a fractured pelvis, and there are some methods we can do to treat that as well. So osteoporosis, this is a systemic skeletal disease characterized by lower bone mass, microarchitectural deterioration of bone tissue with consequent increase in bone fragility and susceptibility to fractures. Normal bone, you can see, looks like a honeycomb of mineral pillars that creates that spongy yet strong foundation for your body to move about. Osteoporosis results as the mineralization of that bone continues to thin, and now this honeycomb looks rather sad, right? It's now thinning out. You no longer see such robust thickness, and obviously this is a lot more fragile. There's about estimated, and this is from the 2000s, so 20 years later, no doubt it's higher. 100 million people worldwide at risk, 44 million people in the US. Hawaii, it's got to be a high percentage, right? 1.5 million fragility fractures in the US, 700,000 spine, 300,000 hip, 250,000 wrist, and 250,000 other. These numbers will only continue to go up as America ages. Breast cancer costs about $13 billion a year. Heart disease causes $19 billion a year, but osteoporosis actually is very expensive as well. And I say this, it's really interesting to me that when we talk about women's health, we talk about breast cancer, we talk about cervical cancer, we talk about uterine cancer, but osteoporosis is very women's health too. Most of this is in the women's, affects women disproportionately. We also see a lot of neurological disease that's predominantly women, but we only talk about breast and ovarian and uterine cancer as women's health. So that's my beef. I wish we'd expand the definition. But osteoporosis, also very expensive. 2002 estimates, there were about $17 billion of spend in hospitals and nursing homes for osteoporotic fractures, $46 million daily. And, you know, my guess is we've had more inflation than this. We're probably above this at this point. So what does this look like? If you look at a tissue sample, this is someone's preserved spine. It's kind of gross, right? This is the red marrow. I don't know how many of you guys probably should make this joke. I'm not going to make this joke. I will, if anybody wants to hear this bad joke afterwards, you can ask me what I didn't say. So an insufficiency fracture of osteoporosis, this is the marrow space. You can see the red. This is both blood-producing marrow and fat. And this is a healthy vertebra. This used to be a vertebra, and right now it's become a pancake. You can see a little bit of residual marrow here. The rest of it's collapsed. So this is what happens when you see somebody with a spine fracture. And when the trabecula looks like this, all this honeycomb, you can imagine that any additional stress, more than it can handle, makes it collapse like a marshmallow. And then it becomes flat. Now, sometimes the fracture plane just cracks the top surface, the roof collapsing or the floor collapsing, and the outer surfaces still are open. This one has got some of that. It's rounded rather than completely a flat plate, but you can kind of imagine how this happens. When you have this, some of it remains, but this is the anterior margin, this is the side next to your spinal cord, and now you have a wedge, and so we call this a wedge fracture configuration. One other thing that you guys should know, young people, this happens during, you know, they have a fall and they land and this extra pressure on their vertebral body compresses it. When you have osteoporosis, even normal stresses can cause fractures, and that's why we really worry about frail bones. So back pain is the number one cause of years lived with disability in the United States. 550,000 to 750,000 vertebral fractures per year, 150,000 hospitalizations per year, increased mortality at 5 and 10 years from people with vertebral fractures. We project osteoporotic fractures to increase in both numbers as we age and as the country ages. Spine fractures typically have 2 weeks of disability per fracture. Hip, which we are all terrified of, 18 days per fracture. So kyphosis begets kyphosis. This is a thing that you get, and you are more likely to get more. Why? Because in a normal spine, these boxes distribute the stress relatively evenly, right? This is a little cylinder, it's a little mini pillar, and if it's all intact, it distributes the stress in the front, the back, the left, and the right about evenly. But once you start having kyphosis, this angle, when you are leaning forward, the front part of all of your vertebral body gets more stress. It's just physics. And the more that happens, the more you're likely to get wedge compression. The more wedging you get, the more wedging happens. And so all of you should sit up straight in your chairs. And this is that picture, right? So any of you that remember your physics, your mechanical engineering, once you start having this wedging, the forces on your spinal column change, and there's actually more stress on the front of every vertebral body. And that's why kyphosis begets kyphosis. The more you have this dowager hump, the worse it will get. And of course, if you're already getting it, you probably already have osteoporosis. So how do we diagnose this? We can still use plain films. We can use just a flat X-ray, but sometimes that's not enough because the vertebral body hasn't compressed very much. So the best ones are probably an MRI. A CT can show it, but if there's not much of a break in the outer bone, you may not see it. On an MRI, we see edema, we see fluid swelling in the marrow space. So in this, what you're seeing is a fractured bone. In this, it's obvious. These two pieces are far away. The height of the vertebral body is now shorter than the adjacent ones. You see it's brighter. That on this T2 weighted image represents water, fluid, swelling, inflammation in the marrow space. And you also see in this fracture that part of it is pushing backwards. This is the spinal cord here. And so when you get a bad compression fracture, pieces of it can move and crush the spinal cord. So it can harm you by the pain. It can harm you by pushing on your spinal cord. It can also harm you by so much pain that you can't stand up. And if you can't stand up, your muscles atrophy. If you can't stand up, you're at risk for getting a pulmonary embolus, for your veins to clot. And so these are all of the reasons why spinal fractures and hip fractures are so highly associated with early death. All of these things are going wrong. You're not breathing well, you're not moving well, you're not moving your blood around, you're clotting, your muscles are atrophying. The other thing is, what we'll do also is when we get the MRI, we'll compare to where your pain is, a patient's pain. So if the patient's pain matches where we see the abnormality on the imaging, then those are the patients we think have a symptomatic fracture. Okay, so what are the treatment options? Obviously, the first one is do what we used to do 4,000 years ago. Nothing. We leave you in a bed, strap you up, try to keep you straight, and wait till it heals. Nothing wrong with that. This is actually what we do for young people. I still think that's a little messed up, but you know, if you're a 20-year-old and you have a spinal fracture, actually insurance companies often don't pay for us to fix it. So the next one is vertebral augmentation. So this is the newer technology. What we do is we pass a needle into the bone and then fill up the broken bone with cement. And the objective here is to fuse the bone back and get it stable as fast as possible, and we'll talk more about how that looks. There are three general groups of patients right now, types of procedures that we do with vertebral augmentation. One is the so-called vertebroplasty. This was developed in France and brought to the US. I actually trained with the guy who did the first vertebroplasty in the United States. And what it is just simple, a cement fill right into the bone. Kyphoplasty was developed a little bit later with the idea of actually jacking the bone back up. So if there's partial collapse, you use a balloon to inflate the bone, and then you put in the cement. So try to restore some of the normal shape of the vertebral body and improve a little bit of the height. It doesn't work that great. It doesn't actually typically increase height very much. It was great to sell a couple $1 billion of, trade. But the spine jack and a couple other ones that have followed, this is literally a car jack. We'll show you a picture later. These are a bit more effective at restoring height and shape. Now the next, there's open surgery, and these are better options when you're in good physical health. But as we age, we become less good surgical candidates because there's so many other complications that can occur in surgery. So when somebody has a spine fracture, this is what we think about. Let them heal naturally. Use spinal augmentation or open surgery to try to fuse the bone and fix the deformity using open surgery. So conservative management, you all know bed rest. You probably have friends or relatives that have been in this situation. They have fractured something and they sit in bed for weeks. We have immobilization devices to try to keep you straight and reduce the amount of movement in your spine. When I see patients with a fresh fracture, if you touch their bed, they jump, or they don't jump, because literally just the shiver in the bed ignites all sorts of pain in the spine. So I call that my bump test. I come up and I go, and I don't actually hit the bed because I think that's cruel, but there you can already see the patient's like, don't hit the bed. I know this is going to hurt. And then so the problem with orthotic braces is they don't help that much. Anybody's been in one of these things, they're not comfortable, and it really doesn't solve the problem, but it makes us as doctors feel better. Pain medicines, I don't need to say anything about this, but the problems with pain medicines, and other than addiction, other than opioid abuse, is that it dulls your brain. None of you want your brains dulled. If you did want your brains dulled, you wouldn't be here on a Saturday morning listening to us, right? Second, if your brain is dull, you're increased fall risk, right? You're, ooh. So you could go from 1 fracture to 2 fractures. Constipation. I remember when I was a young man and my friend told me, my dad struggles with constipation. I'm like, whoa, that's weird. Now that I'm older, that's really scary. Constipation's no good. And of course, opiate abuse and opiate dependence. Yeah, can you imagine this one? This just does not look comfortable. Can you imagine this bra? Yeah, okay, let's not talk about this. This is like a horror movie. Other things, there's a human cost of having this, right? Decreased activity. You can't do what you love. You can't exercise. Increased rates of depression. This has been shown. Lower self-esteem. You can't play with your friends. You can't can't visit the museum. You can't attend lectures at University of Hawaii. Increased anxiety, diminished social roles. You can't help your family. In fact, you go from helper to the one that's dependent. And the other things, your pulmonary function. The more kyphosis you have, the smaller your rib cage is, right? If you're crushed over your lungs can't expand, maximum expansion. So your breathing is more labored, less vital capacity. Every vertebral fracture reduces your lung capacity by about 9% forced vital capacity. And when you have worse lung function, I don't need to explain that to you, that's not comfortable. So why do we do vertebral augmentation? What is it? It's a minimally invasive way to improve biomechanical stability. So I wish we had better cements, but right now what we use is methyl methacrylate. There are 2 other compounds that we use, but they're extremely expensive and insurance doesn't pay for them. But basically we're using medical grade cement to fuse these. We go through about a 1 centimeter incision, and then we introduce a coarse, a very thick needle right into the bone, right into the marrow space, and then put in that into the marrow space. It has been proven, shown through multiple trials, to improve pain, prevent subsequent fractures of that level, decrease morbidity and mortality compared to non-surgical management. So patients that I've treated very frequently within a day, later the same day, they can get up and walk. And when I bump their beds, they no longer go. Typically, the patient will still have muscular pain because we had to go through the skin, we had to go through the muscle, but the bone pain is substantially reduced. So what does it look like? This is the procedure. So this is the vertebral body. This is the spinous process. And this is where your spinal cord lives. Now, this image is a little bit deceptive. Obviously, we don't want to go through your spinal cord. That would cause more problems. So what we're doing is actually going through the pedicle. So you can see this little guy here, this needle, we're not aiming here, we're aiming here. So this pedicle, this little column that connects the vertebral body with the armor that goes around your spinal cord, that's the tube that we aim through to go. And apparently I can't aim well with this laser pointer. Okay, man, maybe I shouldn't be a surgeon. Okay, did it. So this is what we're trying to do. And we used to do this on 2 sides. But now we have techniques and needles that allow us to do 1 side at a time and get the entire vertebral body. And this is an example of, this is through a cadaveric, this is not in a bone in somebody, it's outside. So this is how we target, we go through this angle, and we're able to get into the marrow. This is a straight needle approach. So I feel like I need to come back and do remedial laser pointing. So this is a straight needle approach to get the entire vertebral body. So we'll infuse this entire thing with cement. And this is the kyphoplasty version. So in this beautiful ad, you can tell it's an ad because it works perfectly. So you introduce this balloon, you inflate the balloon, and magically this bone opens up and becomes normal shaped, and then we fill the cavity with cement. This in real life doesn't happen very often. The kyphoplasty maybe increases the height by 5% or so, and then you fill the rest of it up. It works for pain, but doesn't work very well for restoring normal shape. This one is actually pretty good. So they found a good case. So this happens more frequently when you have a very new fracture. So let's say 3 days after the fracture, before the bone starts healing, you have a better chance at getting height restoration. So this is an example using a curved needle. These curved needles allow us to navigate inside the bone a little more, in a more sophisticated fashion. So this is an almost collapsed vertebra. You can see it's how thin it is. This is a tall normal vertebra. This one's now maybe 20% that height. So, and we expand this balloon for kyphoplasty and then inject the cement. This is the cement, this dark stuff. And this patient was actually done here in Hawaii, and immediately post-procedure had a reduction in pain and was able to walk again. So data on vertebroplasty, we've had a large heterogeneous volume of data, reducing pain compared to non-surgical management. The first randomized trial, this was actually conducted by one of my mentors who's now division chief of neurointerventional surgery at Mayo Clinic. This was negative. We all hated him for this study because we've all seen it work, and we're like, what the hell did you do, Dr. Kalmus? Actually, it's even worse. I have a couple startups that I work with his sons, so I'm actually quite conflicted, but I love the guy. He has the courage to publish this trial despite the fact it was negative. What we found was he had the wrong metrics. He was using metrics that really didn't capture what was going on with the patients. Subsequent randomized trials have shown that vertebroplasty does reduce pain compared to conservative management with medicine alone. But we've moved further. Oh, sorry, I missed this. Mortality after hip versus vertebral fractures. So hip fractures are very lethal. You can see that the rate of survival really drops at, when you've had a hip fracture. So immediately afterwards, the death rate isn't very high, but at 5, 10, 15, you're really, that survival curve isn't very friendly. This is the general population. This is the vertebral fracture population. This is hip fracture in women. In men, these are the survival curves. And yes, men die at a higher rate than women. You all know this in the room. I was going to make another joke. I'm not going to make that joke. Okay, and so this is another one. Women with vertebral fractures have a 5-fold risk of new vertebral fracture and 2-fold risk of hip fracture. This is several reasons. One, if you have one fracture, you probably have osteoporosis. So you're more likely because your bones are getting softer. Another reason is your biomechanics are changing. So when you have this, you're straining, you're walking, and your biomechanics and how you move change. So you're not only have weak bones because that's who you are now, but you're now no longer moving in as safe a fashion. Of women who suffer a vertebral fracture, 1 in 5 will suffer another vertebral fracture within a year. So if you have a vertebral fracture, please find Dr. Kamal, one of her colleagues, and get on osteoporosis medication ASAP. The free studies show the benefits of balloon kyphoplasty. This is the balloon method. And so again, this has improved rates of ambulation, function, and mobility compared to non-surgical treatment. I'll get to this now. I don't remember if I have a slide on this topic. Increased rates of new fractures. Why? So when we fuse these fractures, we have now we've changed one of your vertebral bodies from soft bone, osteoporotic bone, to a piece of cement. I don't think it requires a lot of imagination to imagine what that might do to your biomechanics. You now went from soft, squishy osteoporotic bone to a rock. So adjacent fractures to where we do kyphoplasties and vertebroplasties is increased rates. So unfortunately, what we have to do sometimes is kyphoplasty, vertebroplasty at multiple levels because people get one fracture, then another fracture, and another fracture. One of my patients, this is a young man, but he had a rare disease that required him to have constant steroids for the last 30 years. So his bones were literally tissue paper. This is going to sound terrible, but when I put the needle into his bones, I didn't have to use a hammer. I could just push. It just goes right through his bone. He had 6 fractures all at the same time, and we treated him for that. We did 6 levels at the same time because his bones were not evaporated. They were moth-eaten. So how do we select patients? We select patients with positive MRI scans, or if we know it's a new fracture on CT. So new fracture, and we can reproduce the pain there. So we'll tap on gently, tap on somebody's back, and make sure that the pain is at the same place as the spine fracture. We want to, the things that we worry about are patients that have already healed fractures. There's generally not a lot we can do. So let's say this is 6 months out, and there's back pain. The fracture's already sclerosed, the bone is already fused. Generally, we don't get a lot of great results from that sort of thing. It also helps a lot when there's severe pain. So if you have severe pain, you're more likely to benefit because we can eradicate the pain. So we really want to focus on two things. One, eliminate the pain, get you walking again. Two, try to prevent deconditioning, atrophy and whatnot from the other bits. Lastly, if we can preserve the vertebral body height, keep it from collapsing, then that lowers your risk of biomechanical abnormal strain going forward. Preserve your height. I'll skip this slide. This is a flow chart of how we look at this, but we look at imaging, look at symptoms, and if you have symptoms that are worsening and imaging that's worsening and pain that's worsening, that's a good candidate for getting surgery. This is a nasty picture, but these are 3D printed bones of a healthy bone and a collapsed bone. These are the ones we're trying to fill. So what we'll do is typically discharge patients the same day, and normally they can go after about 2 hours of bed rest after the procedure is done, and we typically follow up in about a month. We typically ask people not to do much weight-bearing activity. You know, you're not going to try to do anything that increases stress on the first day or two afterwards. And of course, the most important part, aggressive management of osteoporosis with your primary care provider or geriatrician. Gerontologist, is that the right word now, Kamal? No, geriatrician, okay. So this is a case, a 94-year-old male with a history of osteoporosis, prior left hip replacement after a fall in a nursing home, new T11 vertebral compression fracture with a 20% height loss, old fractures, 10 out of 10 back pain, no neurological deficits. Now, why do we care about that? If you have neurological deficits, basically your spine looks like it's being compressed. That's a reason why we would prefer sending to an open neurosurgery, because there's a piece of bone crushing your spinal cord. And the patient was on Percocet and Tramadol. These are opiates without improvement of pain. So this is what it looks like. This is the fractured vertebra. This is an old fracture right below it. This is the edema inside the vertebral body. This is the collapsed vertebra. It's lost maybe 40% to 40% height. We introduce the needle into the vertebral body. We open the balloon, and then we fill it with cement. And this is the lateral view. This is the view from the front. And the 1 week pain post-procedure, when we saw him again, pain was minimal, 2 out of 10 at worst, off pain medications and walking well with a walker. And this is probably, if we'd done this 2 days after, he'd probably be already close to this state. Other spine intervention, this is where the car fanatics in the room might get excited. Everybody knows what a car jack, a jack looks like, right? We have potholes here in Hawaii, so every once in a while we pop a tire and we got to pull one of these out. So somebody had the great idea of putting this in your spine. The idea here is you simply jack up the broken vertebra. So what we're doing, actually this is a good picture. So this is the partially compressed vertebral body. You then expand the jack. We literally use a screw pump to push this up. And then you reopen the vertebral body and then fill it with cement. So this is right now the best version of height restoration that we've got. Other things that we can do, we do bone ablations for cancers. So sometimes there might be a cancer eating away, and what we'll do is we'll bring in a probe and either use heat, cold, or microwaves to kill the tumor locally, and then fill it back up with cement. So we do those things as well. This is an example of a metastatic lesion in the bone. This was using radiofrequency ablation, so microwave, and cook the tumor, and then fill it back up with cement. We use this for painful spine tumors when there's not a direct surgical option for them. This is one I care a lot about. The first one I did, well, we'll talk about this and then I'll tell you the story. The sacrum is this bone in your pelvis. And you can imagine how important this is for walking. If this is broken, you can't walk. It hurts. Sacral fractures are associated with an 18% mortality, and prolonged bed rest may result in decompensation. What do we mean by that? Again, muscle atrophy, your lungs, your conditioning goes down because you can't get out of bed. So this is an example of a sacral fracture. This is a woman in her 80s with sacral insufficiency. This is our word for saying it's the bone is too soft, too weak. And you can't really see the fracture line, but this line here you can't see the fracture, but right here, this cortex, this bright bone, this should be one solid line. And there's a step off, there's a gap, right? And the same thing over here. Very frequently we see these symmetrically on both sides. The fracture line normally is a letter H on coronal imaging when we look from the front. And so this person can't walk, was bedbound for 2 weeks, and finally somebody had the idea, can you guys do anything about this? Most open surgeons don't like doing these because at 80, you're frail. And then you're putting screws and rods through the tissue to try to fix this together. So not a lot of people do that. But what we can do is use cement again. So what we'll do is put these needles in. I'm using curved needles again. And then we go into the fracture site, and then we fix the fracture. What we do is we just fuse this area, and what happens right afterwards is the bones no longer move against each other, and it deadens the pain. So this woman was able to walk literally the day of the procedure. So I really I do strokes, so I love taking patients that can't talk, can't move, and then right after the procedure, they're walking, moving, and cursing at me because it hurt. And then there's only one time in life where I love people cursing at me. It's when I'm treating them for a stroke. They're like, it hurts, screw you, ah. And then I'm like, yes. So this is another time. They don't yell at me because typically we have them under anesthesia, but afterwards they can walk. It's in stroke care we call it the Lazarus effect. Get up and walk. Okay. So this lady was able to stand the very, very same day, and we were very, very thankful for that. So VAS, this is a scale for their outcomes in sacroplasty. And the answer is your severity of pain and your severity of disability just drops after we do these. So this is a great one. And if you ever have hopefully not a family member, hopefully not you, somebody you know, maybe your enemy, has a sacral fracture, you can send them our way. We'd be delighted to take care of them. ODI is a disability matrix, same thing, just a very sharp drop once we do sacroplasties. And this systematic review of 19 studies on sacroplasty, same thing, it works. Okay, so I'm gonna summarize so you guys can ask questions. Debilitating back pain and limited mobility for vertebral compression and sacral fractures is a large and growing problem amongst an aging population. I'll take a moment to say prevention is better. Let's prevent them. Let's prevent them. And that, I'm sure Kamal has great talks on that. If you do get a fracture, this is a minimally invasive method that we can do to try to reduce the disability and the length of disability that you have after a fracture. Vertebral augmentation and sacroplasty are low-risk, minimally invasive procedures that can reduce pain, improve mobility more quickly, and prevent subsequent fractures. Bone health matters. I tell my wife to drink calcium all the time. Support your bones support you. Thank you. Sir. I'm just a carpenter. Ask the doctors. No, but in all seriousness, I don't keep up with the data on the best current osteoporotic prevention measures. So work with your primary care physician or your geriatrician.
What point in your age are you sensible worrying about the state of your
we're all should be worried. So basically, you hit your peak mineralization in your 20s, and it's downhill after that. In this room, I can tell you, all of us are at risk, particularly women. We know that osteoporosis affects Caucasians and Asians at a higher degree than African Americans. I do not know the data for Native Americans and Pacific Islanders. We don't have that data. More research we need to do, right? But you know, that's why we should all be vitamin D, calcium, and if we have low densities, getting the drugs to support bone health.
One more question quickly. I'm 77. I walk 7 stories up and down 3 times a day.
Yeah.
I run around Kapilani Park. I swim out to the Zoc. I have nothing. I can run as fast faster than I could in high school.
So, I think we need his diet and regimen. In all seriousness, I would defer to my colleague, but my guess is that a simple plain film X-ray to look at the density of your bones or a density scan to just see if you're well mineralized, I think that's a good preventive measure. Mm-hmm. We do colonoscopies, we do all sorts of other types of screening. There are very low radiation ways of looking at your bone density. And if you look like a 22-year-old, keep running, keep doing all these things. But if you do have demineralization, I'd consider starting to take supplements.
Thank you.
Are there any more questions?
Is it calcium has any minimum, the age related or the bone density related? How much calcium we will take?
I will defer to the real smart people in the room. Again, just the carpenter. Kamal, do you have an answer for that?
Yeah, so I think you really need to talk to your primary care physician. There are some recommended calcium and vitamin D recommendations for the diet and for supplementation. But for certain patients, who may have kidney stones or whatever, there may be different recommendations. So it's really important to ask. I do caution everyone, vitamin D is a fat-soluble vitamin, which means if you take too much of it, it will be toxic. There's certain vitamins like the B vitamins, which are water-soluble. If you take too much, you'll just pee it out. So you'll have very expensive urine, but you won't have any problems. But A and D, you can get toxicity. So again, it depends very much on your medical history and what's happening with the rest of your body. So please, even with taking supplements that are over the counter, check with your doctor. Okay.
Hi, are most of these like VA and procedures, are they covered by insurance?
If there's osteoporosis or cancer or a tumor, yes. It's the young people that we actually have a hard time getting covered.
Ferdinand, some of the people online are saying, could you repeat the question before answering, because they're having trouble hearing it.
Okay. The last question was, does insurance cover these procedures?
Hi. My question is, what I hear most about back issues are people saying that their vertebra, like the L5, is being fused to the SI. Is that the same as vertebral augmentation? It's completely different surgery, no cement?
Correct.
Could you repeat the question again?
So I'm going to repeat the question. Yeah. The question from the audience was, is vertebral augmentation the same as spinal fusion? The answer is no. Spinal fusion, they're typically the spine surgeons and neurosurgeons that are doing this is when you have unstable backs where there is movement in your spine or compression of your spinal cord or your nerve roots because of the degenerative disease there. And then they do the spine surgeries to try to decompress what's affecting your nerves and stabilize your back. These procedures are directed towards vertebral body fractures that are causing pain.
So no cement in the fusion?
Not typically. There are going to be variations where open spine surgery will use cement, but the majority will not, 90% or more.
Thank you.
Are there any other questions? I don't see any online right now.
I wanted to ask you if someone has osteoporosis and is also losing height by several inches, are there some things they can do to make it not get worse, so they don't end up having to have all this surgery and everything?
The question is, if you have osteoporosis and you're losing height, are there things that we can do to prevent further loss of height and obviate the need, not need surgeries? Again, prevention. So trying to keep your mineralization up. There are supplements and drugs to improve bone density. There are about 2 big reasons why you lose height as we grow. One is the bones, microfractures, and starting to compress, not even full fractures. Obviously, a full fracture and collapse of the vertebral body, that will cause height loss. Another reason, though, is the discs between your vertebral bodies. They become dry and thin as well. So you lose height in your discs, you lose height in the vertebral bodies. So those are things that will compress your spine. I haven't seen anybody study this, but I wouldn't be surprised if some changes in your femur, your legs also occurs. Everything ages, everything changes, but I have never seen anybody publish on that. But we absolutely know your spine shortens as we age.
The same as a knee problem, just you can fix knee like the same way?
Not yet. Oh, the question was, can you fix knee problems this way? The answer is not yet.
What is your comment on use of Prolia medication?
I'm sorry, Prolia?
Yes, Prolia.
I apologize. The question is, what are my comments on Prolia? And I will plead the fifth yet again. I'm just a dumb carpenter and plumber. I do both, actually. But I will defer to the primary care on the drug.
We actually, in the spring session, many of the participants did ask for osteoporosis as a topic, and that is going to be a topic for next year's mini medical school, just to let you know. And we will have an osteoporosis expert come and talk to you about all of the different medication options that are out there, the pros and cons of each one. So come back.
Yeah, thank you much.
I think I'm going to attend that one.
Yeah. Are there any other questions in this room? I don't see any online. One last chance. Oh, there's another one. Okay.
This is a question about you. You know what the dangers are.
I'm sorry?
You know what the dangers are for everybody, including yourself. What are you doing to protect yourself?
Exercise. So weight-bearing activities absolutely strengthens your bones. You're doing the right thing. Healthy, balanced diet would be where I would be. That's what I'm doing to protect myself. My wife does not drink milk. I try to make her eat cheese and take supplements. We just had 2 kids, so the babies leached as much as calcium and bone out of her as they could. So those are the things that we do, and I think that's what we all should be doing. And at some point when we find out that we have osteoporosis, that's when we start using the medications and supplements.
I think the exercise is a wonderful point. Yeah. So weight-bearing exercise of any kind is very helpful for the bones.
Thank you. Any other questions? Thank you guys for putting up with me. Pleasure meeting you all.